Okay, so you've got a fibroepithelial lesion on your scope. One of the very first and most critical questions you have to answer is this a Phyllodes tumor? Getting that call right is absolutely crucial for the patient, and it really all comes down to knowing the CAP protocol inside and out. So in this explainer, that's exactly what we're going to do. We're going to walk through it step by step. And just so we're all on the same page, everything we're about to cover comes directly from the official playbook, the College of American Pathologists Protocol, version 1.1.0.1. This is the gold standard you'll need to meet in your reports. So here's our game plan. We've broken this down into 5 parts. First, we'll touch on why these tumors are such a unique challenge. Then, we'll dive right into the main event. Is it benign, borderline, or malignant? From there, we'll look at the 5 key clues for a malignant diagnosis, cover the essentials like margins and staging, and then wrap it all up with an essential reporting checklist for you. So let's start at the beginning. Why is there such a detailed, specific protocol for this one tumor? What makes it such a challenge in the first place?
Well, picture this. A breast lumpectomy with a fibroepithelial lesion lands on your desk. Right away, you're at a critical fork in the road. You have to distinguish it from a fibroadenoma. Because the second you call it a Phyllodes tumor, that starts a whole new diagnostic cascade. And the next question becomes even more important for that patient's treatment.
And that brings us to the absolute core of the protocol, which is answering that central diagnostic question. Is this thing benign, borderline, or malignant? The grade you assign here is going to directly influence everything that comes next, from the surgery to the follow-up. This table from the protocol is basically your roadmap. It breaks the whole thing down into 5 key histologic features. You've got stromal cellularity, atypia, overgrowth, mitotic rate, and the tumor border. And as you can see, there's a really clear progression for each feature as you move from benign over to borderline and then to malignant. This framework, it's the foundation of every single diagnosis you'll make. Okay, now let's zoom in on the highest stakes call you can make, diagnosing a malignant Phyllodes tumor. This is where getting it right has massive clinical implications. I mean, we're talking about the difference between a risk of local recurrence and the potential for distant metastasis. The protocol is super specific here. This isn't a looks kind of bad judgment call. It's a diagnosis of inclusion, meaning specific criteria have to be met. And the protocol's notes put it pretty bluntly. To make a diagnosis of malignant Phyllodes tumor, you have to find all 5 of the key features. Not 4 out of 5, not most of them, all 5. This is a hard and fast rule you've absolutely got to commit to memory. So here they are, that 5-point checklist for malignancy. You need marked stromal cellularity, marked stromal atypia, stromal overgrowth, an infiltrative border, and a high mitotic rate. Let's take a closer look at a couple of these that can be just a little bit tricky. First up, what exactly is stromal overgrowth? Well, the CAP protocol gives us a really practical scope-side definition. All you have to do is find at least one low-power field, so on your 4x objective, that is nothing but stroma. No epithelial glands, no ducts in sight. If you can find a field like that, check the box. You've met the criteria.
And now for the feature that often takes the most work, the mitotic rate. The magic number, the threshold you're looking for to call it malignant, is this one.
That's 10 or more mitoses per 10 high-power fields. And a really critical piece of advice from the protocol is that you have to do this count in the most mitotically active area of the whole tumor. You have to hunt for that hot spot to make sure you don't undergrade the lesion. And just to lock these numbers in your head, for benign tumors, you're looking at fewer than 5 mitoses per 10 HPFs. The borderline category is that gray area in the middle, from 5 to 9. And for malignant, you have to hit that firm cutoff of 10 or more. Now, there is one scenario that can completely override that all 5 features rule. If you find malignant heterologous elements, I'm talking things like osteosarcoma, chondrosarcoma, or liposarcoma, the tumor is automatically malignant. But there's a very important caveat you need to know about. And here is that crucial exception. If the only heterologous element you find is well-differentiated liposarcoma, that by itself is not enough to call the tumor malignant. You'd still need those other histologic features. This is a well-known potential pitfall, so definitely keep it on your radar. Okay, so you've nailed the grade, you've figured it out. But your report is definitely not done yet. Now you have to provide the essential information that the clinical team needs to decide what to do next. And that means we need to talk about margins, nodes, and stage. So let's be crystal clear about margins. In the world of Phyllodes tumors, a positive margin is defined simply as ink on tumor. The distance is 0. It's either positive or negative, that's it. And this is such a vital piece of information because it's one of the main things a surgeon uses to decide if the patient needs to go back to the OR for a re-excision.
All right, next step is staging, another area where it's easy to get tripped up. So let me ask you, when are you actually required to provide a PT&M stage for a Phyllodes tumor?
The answer could not be more clear. You only apply staging for malignant tumors. The CAP protocol is explicit about this. You do not assign PT and PN categories for benign or for borderline tumors. If it's not malignant, you just say staging is not applicable. End of story. Now, for those cases that are malignant, the PT category is staged using the soft tissue sarcoma guidelines, which is based completely on the tumor's greatest dimension. As you can see here, the key size cutoffs are at 5, 10, and 15 centimeters.
All right, let's bring all of this together into a final, actionable checklist. Think of these as the absolute must-haves for every single Phyllodes tumor report you sign out.
So, to wrap it all up, here are the 5 key elements your final report has to include. Number 1, the final grade. 2, a statement that you've looked at all 5 key histologic features. 3, the specific mitotic rate. 4, the margin status. And 5, the full pathologic stage. But remember, only if it's malignant.
So there you have it, a clear guide to navigating the CAP protocol for Phyllodes tumors. You now have the framework to accurately diagnose and report these really complex lesions. But, mastering the protocol is really just the first step. The deeper question to carry forward is, how do these histologic features we've just been talking about actually correlate with what happens to the patient, with their outcomes and their risk of recurrence? That's really the next level of understanding.